So what we wanted to do today is to begin to scope out how health economics might be used in Chorus, and already some of the teams are using various health economics tools, so this isn't totally new, but we thought it might be helpful to lay out the terrain to show that a variety of tools that might be used at different stages of the Chorus projects. So I'll do a little bit of that, and then Bryony will look in a little bit more detail at one of the tools, only a little bit more. And I think we would both say that almost certainly we'll need further webinars or training on particular tools as we progress through Chorus, if they turn out to be useful for the teams. So this is just definitely at a general level. So the way we'll do it is I'll talk and lay out the sort of overall tools that might be used. Bryony will then talk a little bit more give a little bit more detail on economic evaluation, and then we thought we would go into some breakout rooms by country partner, and in order to think through what tools might be most useful to your team. But I think we both see this as the start of a continuing conversation. So firstly, I know some of you have economics background, but I thought I would start from the basics. What is economics? There's a usual, I think non-economists often think of economics all being about money. And I think economists would say, well, money is often useful as a way of exchanging, as a medium of exchange, as a way of trading with each other, for example, but it's certainly not essential to economics. And economics happened, economic relations happened even before the advent of money and through barter trades. One definition of economics that's often used is that it's the study of the allocation of scarce resources amongst competing ends. So this is the idea that most resources, perhaps all resources, even clean air, clean water, those are scarce. And so the economists would study how those resources are allocated, are used, are distributed to different parts of society, to different parts of a country. I think slightly more actively, so the first definition is essentially what is happening, it's a description. Slightly more actively, we have a fuller definition, which is that economics is, it's firstly the study of the allocation of scarce resources, but secondly, it's also trying to understand whether that allocation achieves certain societal or policy objectives. And finally, how those resources might be reallocated in order to better achieve objectives. And I think certainly most of health economics is focused on this broader definition, focused not only on what is, but also on what should be according to normative definitions of societal good. And health economics basically applies the study of economics to the topic of health and also healthcare. So essentially the question that we're looking at briefly this morning is, how can health economics and health economic techniques be used to assist with Chorus projects at different stages? And in order to understand this question, in order to answer this question, I think we need a little bit more understanding about what health economics might do, what the scope of health economics might be. So typically when we talk about health economics, we start with where resources come from, and then it flows down to how they're allocated and how they're used. And I've structured this presentation basically around that. So firstly, a first stage of understanding might be to understand how resources are mobilized and utilized. Where do resources come from? Secondly, given those resources, what are the implications for equity of current and future funding and distribution of those resources? I'll go into a little bit more detail on these in a minute. Thirdly, once we've seen how the resources are distributed, and we've decided what interventions might be used in order to utilize those resources and deliver health gain, do the proposed interventions offer good value for money? And then finally, are there incentives in place to encourage and enable the interventions to be implemented? And I think all of these questions could be relevant to Chorus. So let me start on the first one. How are resources mobilized and utilized? So I think there are, in terms of tools and techniques, there are three complementary tools that might be useful to understand where funding comes from for health. And in our case, it's urban health, and specifically urban health for the poor and those living in marginal communities. There are three complementary tools that might be useful. The first one are a set of tools that are typically known as national health accounts, although the same tools can quite easily be used to develop local health accounts or even city health accounts, and perhaps relevant for what we're doing in Chorus. And essentially what a national health account or a local health account does is that it describes all the public and private sources of funding for health, and then how they're distributed to providers. We use the National Health Accounts framework in our session on the private sector, which was done earlier in the year, in about March, I think. So that's an overall description. Then the second tool that's useful, related tool, is the public expenditure review. And the public expenditure review is a useful tool for going into a little bit more detail around how public funds are used. So it's a description of how public budgets are formulated. It provides, one of the ideas is to provide a better understanding of how they're formulated, give a better understanding of the planning and budgeting cycle. And I feel this could be really useful in Chorus, because if we're going to sustain interventions in the future, we need to know how those interventions might be incorporated into a planning cycle and then budgeted for by government. And then finally, the final tool here are public expenditure tracking tools. And essentially public expenditure tracking looks at what is, and it compares, what should be, and it compares it with what is. So it looks at whether the resources that are being promised for, in this case, urban healthcare, do they actually get to their intended uses? Do they actually lead to better funded primary care, better funded hospitals? Or is there some blockage due to mismanagement or corruption or many other issues? So public expenditure tracking tools also a useful tool for understanding whether the resources that are promised actually get to service delivery. And as I said, Romana will be talking a little bit about, I think, all three of these tools in her presentation in a few weeks' time. So that's one set of tools, the first three. The second question that I raised is, what are the implications for equity of current and future funding and distribution? And I think this is a particularly given our context, these are really important questions. So when we're not only interested in how much money is available for urban health and whether it is allocated to health facilities, but we're also interested in the equity implications, which population groups benefit and which don't. And essentially there are two parts to this tool. The first is to understand something about the sources of resources. Who is paying for healthcare at the moment and also later in the future once interventions are introduced? And health economists are typically interested in two areas here. Firstly, how much on average do people pay for healthcare, and that might be through taxation, or it may be out of pocket, or in other ways. But also, we're often interested in any catastrophic impact of healthcare expenditure. And by that I mean, when you get ill, you often have to make huge payments in order to pay the hospital or primary care facility, or in order to receive treatment. And such catastrophic payments can easily bankrupt a household or an individual. So we're interested in not only the regular payments, but also these so-called catastrophic payments. So that's one part of the equity equation. The other part, the other part that we're interested in is, once we've got the money, how is it allocated? Who benefits from the public spending? Who benefits from the spending in hospitals, or and this is mainly true of most of Project One, who benefits from primary care spending? There are several tools here that are useful. One is benefits incidence analysis, which simply looks at cross different groups and looks at who benefits and who doesn't. So we might compare men and women and find out whether men are benefiting more than women, or vice versa, and understand a little bit about why. We might look across socioeconomic groups. Are the poor are benefiting less or more than richer groups? And we can continue that through different levels of vulnerability, the disabled and non-disabled, different ethnic groups, and so on. The other slightly more complex but related tool here is that we might look at we might look at allocation related to need. So it's usually the case that we don't expect that everyone will use the same health resources. Some people have more than others. So it may turn out that if it turns out that the poor not only the poor have more need than the richer groups, not only do we want them to receive the same benefit as richer groups, but actually more benefit, because they have more needs. So we need to relate the allocation to need as well. So that's the sort of the way in which the funding is allocated through the system. The next question, and I think this is a really important question as we go into the co-creation phase of Project One, is, do the proposed interventions or services offer good value for money? And there are two parts to this, and Bryony is going to come back to this in a minute, so I won't dwell on it too much. But the first one is around the first tool here is costing, to understand how much a particular intervention costs, the level of resources that go into an activity in order to sustain it. And this often has two parts. One is, how much does it cost to establish, say, a pilot intervention or an intervention in one area, as we might do within Chorus. But the other part of this is that we want to know what are the consequences for a city or for a country to scaling those interventions. So how much does it cost to scale up? And we want to get an understanding of what are the potential economies of scale. So the unit costs may fall as you scale up, or it may be the other way around. And then the second part here is the cost effectiveness. So this is essentially where we put together the costs with the benefits, and we look at whether the intervention really offers good value for money compared to other uses of the same money. As I say, Bryony will return to this in a few minutes. The final area, as you can see, this is a really quick whisk through the types of tools that we might be using Chorus. But the final area is, do the incentives in place, and by incentives I mean things like the payments to health facilities, the types of salaries, or the way in which we pay health workers, do the incentives encourage the interventions to be implemented? So once we have a so-called cost-effective intervention, what happens in practice, and do the incentives encourage that? And here again, we have two areas or two tools here. The first one is around provider payments and contracting. So this is about, how do we set up a contract in order to reward, say, a primary healthcare facility to ensure that they deliver the package that we're developing. So, for example, in Bangladesh, you're developing a modification of the pen package. It will be provided through primary care facilities. How do we pay that health facility to ensure that they really deliver those services in a quality way, and in a way that's good value for money? And then finally, we have the demand side, and one of the things that's become apparent over the last few decades is that often it's not sufficient just to look at how you pay providers in order to ensure services are delivered, but you also have to look at the financial barriers faced by individuals in reaching health facilities. So healthcare may be free once you get to a health facility, but what are the other barriers? For example, the transport barriers, or having to have someone accompanying you to a health facility. So that also costs, because maybe they have to take a day off work. So we have all these financial barriers that are important. And there's been a growing interest in demand-side financing to try and look at those barriers and try and overcome them. For example, providing payments for transport so that people can get to a facility. So that's the nine tools or techniques that I wanted to just overview. Before I hand over to Bryony, I wanted to come back to how we might relate those tools to our projects, and this is something we can talk about more in the breakout groups. So I think we could use these tools at several different stages of our projects. Firstly, the project needs assessment, and I know obviously in most cases the needs assessment is well underway, and in fact nearly finished in some countries, but there may be an opportunity still to include some of these tools in the remaining needs assessment for project one, or indeed the needs assessment for the next projects, or for some of the innovation fund projects. So I think there are a number of areas where we might be interested in bringing some of these tools in. The first is, if we're trying to understand what resources are available for urban health and urban healthcare, then some of the public expenditure management tools that I mentioned, and the National Health Accounts, Public Expenditure Review, Public Expenditure Tracking, could be useful to understand how much money is available at the moment for urban healthcare from public budget, but also perhaps from NGOs and from households. So we know what the overall resources available are, to give us an idea of what's going to be affordable in the future. Who currently pays for healthcare? What is the impact on different population groups? Might also be important in understanding the overall context. And here we've got the use of the equity analysis tools, both the equity analysis of where the money comes from, but then how it's allocated. So that's at the project needs assessment stage. As we move into implementation and then evaluation, I think there's also a need for health economics tools, and I think we've acknowledged this before when we thought about how some of the projects might develop. So firstly, in terms of the co-creation, which services should be funded and how the services should be organized, the techniques of costing and cost effectiveness analysis could be very, very valuable. Now, we could wait to do a cost effectiveness analysis until we get to the evaluation, but it may be useful to even begin to think about doing costing and possibly even cost effectiveness analysis as we enter the co-creation stage. Maybe a costing could be done in draft form to begin to get an idea, to scope out how much an intervention would cost. And if it turns out to be extremely costly, we might modify the intervention. Because we realize it won't be sustainable in the future. So I think it's not too early to begin to think about that costing and even cost effectiveness analysis, even at the co-creation stage. Then as we think through how the interventions will be developed, I think we might also think about how providers need to be compensated in order to incentivize them. How are we going to pay to ensure that, for example, the pen package, as I mentioned earlier, would be incentivized in urban health centers in Dhaka or in other countries. So there, provider payment and contracting and demand side financing might be useful. As we go into the evaluation, we're also going to be sensitive to who is going to benefit from the interventions. So is it really our target group that is going to benefit from the interventions that we're provided through the primary healthcare facilities? Is it the urban poor, or are the benefits captured by other groups because they perhaps live nearer the health facility and so better able to access? So equity analysis could be valuable at this stage. And then finally, we're going to be thinking about scale up and their costing tools to begin to think about the time series modeling. So the costs over time of introducing the intervention. Costing is going to be useful to think about the impact on the public budget and whether the government and whether the state can afford to sustain the interventions that we're developing. So I suggest we'll come back to these in the breakout groups, and I'm going to hand over to Bryony to talk a little bit more detail about the economic evaluation part of these health economics tools. Bryony.
Thank you. I think you're controlling the slides, Tim. So yeah, okay. So as Tim says, I'm going to talk a little bit more about economic evaluation. And the idea is to give an overview of what the different options are and some of the things we need to think about if we want to undertake economic evaluations to evaluate our interventions within our projects. As Tim says, we're hoping this will give a bit of a starting point, really, and help with planning what evaluations might be relevant in our projects. Next. So what do we actually mean when we talk about economic evaluation? Well, a sort of textbook definition is that it's an evaluation that facilitates comparisons between alternative healthcare programs, or treatments, or services, or interventions in terms of both their costs and their consequences. And what that means is that in an economic evaluation, these two components, both the costs and the benefits or the outcomes, are compared simultaneously, so that in making a decision about which of the alternatives is the best option, we consider the costs and the consequences of each option and evaluate their relative merit. Next. Okay, so why is economic evaluation important, and why should we consider doing this sort of analysis? Well, it's important because no healthcare system anywhere in the world has achieved levels of spending on healthcare provision which is sufficient to meet all of its population needs and wants for healthcare. And what that means is that there's limited resources for healthcare, and so decisions have to be made about what should be prioritised to meet healthcare needs in the best way possible. And so economic evaluation is important because it can be used to provide evidence on the best way to use the resources that are available, to meet healthcare needs of the population. So it's actually a really powerful tool to motivate healthcare decision-making and investment, and can be really important for encouraging advocacy for healthcare treatments, strategies and interventions that can effectively improve population health. Next slide. Okay. So if we want to do an economic evaluation, there are a few main techniques that we could consider. We could consider a cost minimization analysis or a costing analysis, where alternatives are considered equivalent in terms of benefits or outcomes, and so only the costs are compared. Or if there are possible differences in terms of benefits and outcomes between alternatives, then we might consider a cost effectiveness analysis, a cost utility analysis, or a cost benefit analysis. In each of these, both the benefits and the costs are compared, but the main difference between them is the way that the benefits are measured. So in cost effectiveness analysis, the benefits are measured in physical units. So that's health outcomes that can be directly measured. So things like changes in blood pressure or lives saved. In cost utility analysis, benefits are measured in weighted units, which in practice usually means QALYs or DALYs. And in cost benefit analysis, benefits are measured in monetary terms as well as the costs. So we can think about each of these in a little bit more detail. Next slide. So the first sort of minimum option, if we're wanting to undertake an economic evaluation, is a cost minimization or costing analysis. And this approach is not really an economic evaluation by that textbook definition that I talked about before, because only the costs of the alternatives are compared, not the benefits. And the aim is to identify the least costly approach. But for us to justifiably only consider costs without also considering the benefits, we do really need to have some evidence that the intervention is equally as effective as the comparator, or at least not inferior. But if we can do that, then this is clearly a much simpler and less resource-intensive evaluation. And evaluating the costs can still provide really useful evidence, as it allows us to quantify the investment needed to implement the intervention, and also to inform scale up, which is what Tim was talking about before. So it can be a really good starting point. All the rest of the economic evaluation approaches build on this. So they can provide this evidence, but they also take it further, because by jointly analysing costs and benefits associated with an intervention together, they also tell us the cost effectiveness or the value of treatment alternatives, so that the best strategy can be identified. Next slide. Okay. So another option for an economic evaluation is to undertake a cost effectiveness or a cost utility analysis. In fact, these two are the same type of analysis, and cost utility analysis is actually just a specific type of cost effectiveness analysis. So in cost effectiveness and cost utility analysis, we aim to measure the cost per extra unit of benefit that's generated by the intervention compared with the comparator, which most of the time is usual care. So what's happening with the new intervention compared to what we would normally do in standard practice. And in both cases, the benefits are measured in health-related units. So the only difference is that in cost effectiveness analysis, the health-related units that we use are directly measured health units. So something that can be observed in natural units, like deaths averted, cases detected, or days free from sickness. Whereas in cost utility analysis, the health benefits are measured in composite units of health benefit, which combine quality and length of life, which in practice usually means using QALYs or DALYs. So in this type of analysis, whether it's cost utility or cost effectiveness analysis, we determine whether a new intervention or service is worthwhile or cost effective by producing a summary measure called an incremental cost effectiveness ratio, or an ICER, which measures the incremental cost of an activity relative to its best alternative divided by its incremental effect. So the ISA is calculated as the difference in costs divided by the difference in benefits of the alternatives being compared. And this allows us to compare the relative cost effectiveness of the alternatives to identify the best option. Next slide, please, Tim. The final option for an economic evaluation is cost-benefit analysis, where the net value of different services or programmes are compared by converting both the costs and the benefits into monetary terms. So in cost-benefit analysis, we determine whether an intervention is worthwhile or cost-effective if the sum of the benefits is greater than the sum of the costs. So that's if the net benefit is greater than zero. And this is really useful because this type of summary, if this type of summary can be produced, it's really easy to interpret. The problem, though, is that cost-benefit analysis requires monetary valuation of health outcomes, which can be a bit problematic because it can be difficult to put a monetary value on health outcomes so that we can compare to the costs. So there are some approaches to doing this by linking health with, for example, ability to earn money, or by linking with the cost of healthcare to treat certain conditions. But this can really underestimate the value of health benefits, because obviously health provides more value to us than simply allowing us to work. It actually has a value in and of itself. So we have benefit in and of itself just by being healthy. And that sort of value of health itself isn't really captured very well in this approach. Okay, next slide, please, Tim. So we have these different types of evaluation, but how do we decide which might be the most appropriate for our projects? Well, the answer is that there's not really a straightforward answer, and there's lots of different things that we might want to consider. So we need to think about what outcome to use in terms of what's going to be most appropriate for the research question, but also what's going to be feasible for us to collect within our studies. We also need to think about who will make the decision or use the evidence that we produce, and what evidence is needed or will be most useful for decision makers in our context. And we also need to think about the benefits of the alternatives being compared and whether they are limited to the health sector, or whether some of the benefits and costs will fall outside the health sector, because this has implications for what type of analysis is going to feasibly incorporate these different costs and benefits. Next slide, please. So there's lots of different things to consider, which can be a bit difficult to make sense of. So we've included this flow chart here, which I've called an imperfect guide, because it provides a structured guide to the questions to ask yourself when choosing a type of economic evaluation. But the truth is that most of the time, any of these methods could be appropriate depending on what's going to be feasible and what's going to provide the most useful evidence in your specific context. So you might go through this flow chart and end up with a recommendation of, for example, conducting a cost utility analysis. But as you think about it, you may actually decide that because of feasibility in collecting data, or what's going to be the most useful for decision makers, a different type of evaluation will actually be better in your context. So this flowchart is not supposed to give a definitive answer necessarily, but I've included it just as a sort of tool to help guide the process and give a place to start when planning projects and evaluations, to get you thinking about what's going to be most appropriate in the decision about which type of evaluation might be best. So we'll share these slides in case this flowchart will be useful. Next slide, please. Okay, so I've given a bit of an overview very briefly of the types of economic evaluation, But I just wanted to also mention a few other issues to consider when planning an economic evaluation. Next slide, please. So the first thing to mention is the cost perspective. So it's important when planning an economic evaluation to think about and decide whose costs to include, which is what we call the cost perspective of the study. So the main cost perspectives that we might use are a health system or budget holder perspective, a societal perspective, or a patient perspective. In the healthcare system perspective, we would include direct costs associated with the intervention and the comparator from the healthcare perspective, but costs incurred by others outside of the health system, so like patient costs, aren't included in this sort of cost perspective. And this perspective is useful for providing evidence from a health system perspective on which services should be provided from a specific healthcare budget, which could be for a public service or for a service being provided, for example, by an NGO. The societal perspective includes these same direct costs of healthcare plus productivity costs, costs of absence from work and informal care. So this So this perspective takes a broader view on the costs at a societal level, and so can be useful in informing policy decisions. The patient perspective includes costs of healthcare incurred by patients and can include direct and indirect costs, but the health system costs are not included. So the patient perspective is useful for understanding and demonstrating the cost implications for patients and can be especially useful for evaluating equity impact. So we have to think about whose costs are going to be relevant for our projects and what sort of evidence we want to provide. And of course, it might be the case that we would want to consider more than one of these perspectives. We just have to think about what's most appropriate. Next slide, please, Tim. Another thing to mention is that we should also consider what analytic approach is going to be most appropriate. So in general, we can think about two options. One option is that we undertake our economic analysis based on primary data sources. So that means that we collect data directly within our projects about costs and outcomes and use that data for our economic evaluation. The alternative option is to use a modelling approach, which means that the impact of the intervention and comparator is modelled based on changes to the patient pathway and associated costs and outcomes. And this approach allows data from multiple sources to be used together. So, for example, data collected in the study can be used alongside data from the literature. And there are differences in these approaches in terms of data requirements, the time horizon, and the analytic skills needed, each of which have advantages and disadvantages that we might want to think about. So in terms of data, for analysis based on primary data, we have to make sure comparative data from intervention and comparator groups on resources used, costs and outcomes is collected within our study. And this can have advantages as we're able to design data collection tools and so have some control over what data is available for the evaluation. But we also have to think about whether collecting this sort of data will be feasible in our context. On the other hand, if we're using a modelling approach, we can combine data from multiple sources, which sort of has the opposite advantages and disadvantages. Means that we don't have to rely solely on data collected in the study, but it does mean that we're limited by the data that is available from other sources, as we don't have any control over what's collected in other studies. Although if we know what data is available from other sources, this can inform what data to prioritise collecting in our own studies to fill the gaps. So in terms of the time horizon, analysis based on primary data means that the time horizon for the evaluation is limited to the follow-up period in the study. And so longer term costs and outcomes wouldn't be included if we use this analytic approach. Whereas if we're using a modelling approach, there's more flexibility in the time horizon, and long-term costs and outcomes can be included. So we have to think about whether, for our projects, whether long-term costs and outcomes are important or not. And finally, analysis based on primary data requires data analysis skills, whereas analysis using a modelling approach requires decision modelling skills. So we might have to think about what skills we have and where further training or support is needed. Next slide, please, Tim. So the final thing to mention really is equity. And I don't have a lot of time to say too much about this, but I think it's really important to highlight that equity considerations are becoming increasingly important in economic evaluation, and that extensions to any type of economic evaluation, it doesn't matter which type of evaluation you choose, extensions to that to incorporate equity are possible. For example, simply by considering distributional costs and effects, so the costs and effects that fall to different groups. But there's also, I just wanted to highlight, there's also more advanced methods. So for example, extended cost effectiveness analysis, which presents the distribution of costs and effects, and also incorporates evaluation of financial risk protection. And distributional cost effectiveness analysis, which presents the distribution of costs and effects, and also analyses any trade-offs between equity impacts and health maximisation. So I know I've not given very much detail here, but I really just wanted to highlight that these techniques are possible. And if in your project teams you think that you'd be interested in these techniques, then we can provide additional support with them. Okay, next slide, Tim, please. Thanks. So this is the last slide really, which we've just included because this paper is a really nice example of an economic evaluation of the PEN programme in Indonesia. Obviously this topic has some similarities to some of the projects being undertaken in Chorus, but also this particular paper demonstrates a robustly conducted economic evaluation and also nicely presents the results. So it's a good example to look at to see what's been done